Hello, I'm Michael Cox and I work for CS Health as an exercise physiologist in Lithgow, and today I'm going to be talking about chronic ischemic heart disease. Firstly, we'll just an overview of what we're going to go through today. We'll look at the mechanisms of the development. We'll go over some of the clinical manifestations. We'll then move on to talking about stable angina, unstable angina, and the differences between the two and how they're established. And then we'll move on and we'll talk about the relationship between exercise and chronic ischemic heart disease. So CIHD is a term that refers to the coronary artery's inability to supply the myocardium with sufficient oxygenated blood. Therefore, the demand for oxygenated blood is greater than what the arteries are able to supply. CIHD may also be referred to in different contexts as coronary heart disease, CHD, myocardial ischemia, and coronary artery disease. So ischemia is a decrease in blood supply which can cause reversible injury to the myocardium. So up to 70% of episodes of CIHD may also present as asymptomatic, saying basically they may have a form of CIHD but may not exhibit any symptoms in certain patients. And then the difference for an infarction is the complete loss of blood supply to the myocardium, causing actual death to the tissue, and often results in a result of prolonged and untreated ischemia, also commonly known as a heart attack. So a few statistics here on CIHD. So it's the leading cause of death worldwide. In 2012, 17.5 million deaths, which adds up to 31% of the overall deaths worldwide. 1/3 of deaths for people over the age of 35 in the US of A attributed to coronary heart disease, and most of these diseases that account for these deaths are in some way preventable. So moving on now to the mechanisms of development. So the cause of CIHD is known as atherosclerosis, which is the hardening and narrowing of the artery walls caused by a build-up of plaque, which restricts the normal blood flow to the heart from the arteries. There's two different types of atherosclerotic lesions. The first of these is the stable plaque, which has a small core and thick fibrous cap, and then unstable plaque has a larger core but a very thin fibrous cap. So just going back there, just going to duck over and have a quick look at a visual representation here. So in this video, it's just going to give you a visual of what happens in the restriction of the arteries. So you can see here the normal blood flow is flowing freely through the artery. And then there's the damage to the wall, which allows the plaque to build up, and as a result, it narrows the artery itself and restricts the blood flow, which can lead to a blood clot, as you can see, and this can lead to a complete blockage of the artery, which fully constricts the blood flow, which can, as I said, completely stop the blood passing through the artery altogether. So just a few risk factors we're going to talk about here. So if we just, the first of these is high blood pressure. Tobacco use, which lowers, smoking can actually lower the angina threshold by reducing oxygen carrying capacity of the blood, caused by an increase in carbon dioxide. Hyperlipidemia, which is too much low density lipoprotein in the blood. Diabetes, just an increase in age. Lifestyle factors, is physically active lifestyle, reduce cardiac mortality and decreases risk of atherosclerosis and improves myocardial perfusion. Obesity, family history of CIHD, and so just having a look at the clinical manifestations of CIHD, chest pain, or commonly known as angina, which actually can 35% of patients that present with chest pain will have some sort of stable or unstable angina. Clinical manifestations of CIHD also can include neck or jaw pain, shoulder or arm pain, shortness of breath, increased heart rate, nausea or vomiting, sweating, fatigue, and also can be recognised by changes in ECG, which we'll talk a little bit more about when we move on to unstable angina. So moving on to stable angina, it's chest pain, which is caused by the myocardial ischemia, which is due to the build-up of that plaque in the arteries, which is the stable form of the plaque build-up. It often has a predictable onset. Patients often know their threshold when the onset of angina is likely to kick in stable angina. For certain activities such as walking up and down the stairs, carrying groceries, just day-to-day activities. And it's most likely often caused by physical exertion, or even sometimes emotional stress can trigger attack of stable angina. And so moving on to unstable angina. So it's caused by the plaque disruption, which can lead to platelet accumulation and then the development of blood clots. Unstable angina may also occur spontaneously, so unlike stable angina when it can attack at any time, and it can often lead to causing a complete blockage of the arteries and lead to myocardial infarction. And on a normal 12-lead ECG, unstable angina will sometimes, not all the time, present with a ST segment elevation. And just a bit of a recap here on the different types of the plaque build-up. We're talking about the unstable and the stable plaque. You can see the unstable plaque has a large core and thin fibrous cap, therefore making it more vulnerable to a rupture and possibly full blockage, whereas a stable plaque has a thick fibrous cap, as you can see, which makes it not likely to result in a plaque rupture. So moving on now to CIHD and exercise. So normal exercise response can cause angina in CIHD patients due to the physiological increased demands of them and the reduce of the heart and the reduced supply of blood and oxygen. A sudden increase in heart rate and blood pressure, such as during exercise, can lead to a plaque rupture and possibly a myocardial infarction. A warm up and a proper warm up, proper cool down is critical when dealing with CIHD patients, as it can reduce the risk of this disruption, reduce the risk of disrupting the plaque. Patients with CIHD will often limit their physical activity due to the fear of adverse consequences. Therefore, it's a bit of a cycle. They can, if they're avoiding their exercise, they become further deconditioned to what's already a deconditioned reduce or exercise tolerance. So just moving on to some exercise prescription recommendations. Cardiac, so in the beginning, cardiac rehab was developed in the 1960s after they had concerns about the safety of unsupervised exercise after patients were discharged from hospital. So exercise can improve tolerance when conducted for a period of up to three months, 3 times per week at 70 to 85% of the patient's heart rate maximum. Some recommendations for aerobic type exercise is at least 3 days per week for a minimum of 30 minutes per session at a moderate intensity of around 40 to 60% of the patient's heart rate reserve. And then for resistance exercises, the recommendations are for 2 to 3 days per week. In those sessions, targeting 8 to 10 major muscle groups exercises, and one set of 8 to 15 reps, which can progress to greater than one set. I just have my slides mixed up here a bit. I'll go back to the conclusion. So just some practical applications. It's important to be able to differentiate between stable and unstable angina. A warm-up and proper cool-down is critical for these types of patients. Cardiac rehab is important for improving exercise tolerance and therefore improving the patient's daily functional capacity. And these exercise programs for CIHD patients should also aim to maximise their adherence and also being wary and addressing any of their fear avoidance issues. To my conclusion. So just in a quick summary, so overall CIHD refers to the inability to supply the myocardium with sufficient blood, oxygenated blood. It's caused by atherosclerosis. The two types of atherosclerosis are covered. We talked about the stable plaque and the unstable plaque. And then the stable angina and the difference between stable angina and unstable angina. And cardiac rehab is important for improving the exercise tolerance of CIHD patients overall. And here are all of my references on this slide and the next. And that's all from me, and thanks for listening. Hope you enjoyed the slide presentation.